Hello and welcome to the Doctor's Inn. I'm Marcia Boyles, and I'm delighted, as always, to really introduce the star of the show. It's Dr. Kamaljit, Sethi, who is an internist, primary care provider, physician at the medical center here at Green Spring. Dr. Sethi, I think we have a really interesting topic today. I'm excited about it because it's something that is relevant to all of us. The topic is sleep.
Yes, indeed. You know, of all things that matter to us in life, sleep is very important. After all, we spend an average of a third of our lives sleeping, so it really matters to us, right? And whatever our lifespan may be, about 25 years is how much we sleep in our lifetimes, at least that.
That seems extraordinary, doesn't it?
It is, it really is. And, you know, apart from being such a big part of our lives, sleep disorders are common, and it's important to recognize them. And it's important to discuss this with our medical providers in the same way we discuss other problems. So as an example, one of the things that gets discussed a lot and is brought up by residents is constipation. Sleep should be brought up in the same way, because sleep disorders are a constellation of symptoms. So it may be you don't sleep long enough, you can't fall asleep, or you keep waking up, or you wake up too early. All of them, individually and collectively, are dissatisfying as far as sleep is concerned.
Well, we certainly know it can ruin a day if we've had a very bad night's sleep.
That's true, that's true. So let's talk about how common a problem it is. And while we don't have a prevalence at Green Spring, we do know that approximately 30 million people, rather 60 million people, a third of the adult population, have sleep problems. Okay.
A third?
A third of adults.
Chronically?
No, the chronic number is somewhat lower. A third of those have chronic problems. So intermittently, everybody is going to have a sleep problem. Just think of 25 years. What problem will you not have over a 25-year period? So if you're sleeping for 25 years, you are going to have some problems, right? But the severe sleep problems, what we call chronic insomnia, actually has a definition, and it doesn't matter that much, but just for general knowledge, it means that you have trouble with sleep. I'm using the word loosely, trouble with sleep, at least 3 nights a week, if not more, and at least for a 3-month period. If you've had it for a 3-month period, then it becomes chronic. Fortunately, insomnia is variable. It's not the same at all times. And even those who have sleep problems will say, well, you know, I sleep good some nights, and then there are other nights when I have difficulty falling asleep or staying asleep. And it's important to make that differentiation, because the way we're going to manage that is going to be a little different, right? So in the manner of most problems, you know, we in the United States like to be able to look at what does this do to our economic health, apart from our physical and mental health. What does it do to our economic health? It's an expensive problem, quite expensive. If you look at just the insomnia market, say for drugs, over-the-counter prescription drugs, it's pretty hefty. It's 4 to 5 billion. And to put this into context, you know, when we used to talk millions 30 years ago, we are now talking billions. So much as we complain about big pharma, we contribute to it by prescribing and taking, especially prescription sleep medications in addition to others, okay? So in terms of younger adults, lost productivity approaches 65 billion a year. That's a huge figure to deal with. And it's costly to the government as well. The US government, just in terms of what they spend on healthcare costs for insomnia, it's about 15 billion a year. So it's a costly proposition. But more than the economic cost, is the personal toll it takes on physical health, on emotional health, on the quality of life. And so, you know, it's something that we should be better informed about and deal better with. Don't you think?
I do, and I think your point of discussing chronic sleep issues with your physician is a really important message.
Yes, it is. Do remember that as we get older, there are changes that occur in sleep. So that is to be expected. So
I think we're all aware that we're sleeping differently.
Yes, that's exactly right. Sleeping differently is right. So sleep tends to be fragmented as we get older. And there are many reasons for that. They're not of your making, they just happen. It's like the skin ages, the heart ages. So the same way, the control of sleep, which resides in the brain, also undergoes changes. So there's some changes in the circadian rhythms. Sleep efficiency is reduced, the quality of sleep changes. And so all of these collectively contribute to having fragmented sleep, or sleep, as you say, is different than what it is when one was younger. That's absolutely true. So the important thing to keep in mind when you're having trouble sleeping, the first thought that we should have should not be, well, I'm going to go get a sleeping pill from my physician. So that's one misconception and myth that I want to debunk. You know, the Washington Post has a section about myths, and they use the number 5. I'm not going to use a magic number 5. I'm just going to use one. And I'm going to say, when you have a sleeping problem, just don't think that the answer to it is a sleeping pill.
Right.
It may be, but it may not be. And I tell you why it's not the answer. It's because sleep disorders are associated with both medical and psychological problems. So logically, in anything that we are trying to treat, if we can find the underlying cause, we're going to do a better job of treating it, because you're treating the cause and, you know, eliminating that, or at least mitigating its severity, right? So common medical conditions that can be associated with sleep disorders are, of course, everybody knows chronic pain. If you're in pain, you're going to have difficulty sleeping. So if there's ever time to take a pain medication that will change the quality of your day, it is to take it at night and then perhaps in the morning, but we don't want to go there. We're talking strictly about sleep. The second one is diabetes, because with diabetes there are a lot of changes that can occur neurologically. There's peripheral neuropathy, there is autonomic neuropathy, and so because of all of those changes, sleep patterns may be disturbed. So good control of diabetes is important, and pain control is important.
Yes.
Amongst the mental health issues, there are two which are very important. The one is anxiety. And the reason anxiety is important is because if you begin to worry about something, right, you think, oh, I'm not going to sleep. I know I'm not going to sleep. I will have difficulty sleeping tonight, and you've already to yourself identified the reasons why you're not going to sleep. That is a negative behavior as far as sleep is concerned. And so you will predictably have difficulty sleeping that night, not because you know the reasons why, but because you're setting yourself up by saying, oh, I have 1, 2, 3, 4, which are going to prevent me from sleeping tonight.
Well, the anxiety itself, I would think, would also actually have an impact.
Yes, absolutely, absolutely. And then depression.
Yes.
So we have a significant prevalence of depression. We use
You
a
mentioned
lot.
that 82% of people with depression have insomnia.
That is correct.
Which I thought was a shocking number.
Yes. So depression is very interesting because of the association. Those who are depressed are going to have insomnia much more often than anybody else. As a single risk factor, it's the most significant one. But this is also true that if you don't sleep, the incidence of depression is going to be higher. So this is really a two-way street.
So they're feeding into each other.
They're feeding into each other. So it's very important to identify depression. So Before we get into other risk factors, one of the things I want to mention that we do at Green Spring, which is very good, is that we've tried to take people away from drugs mostly, but when we do have to use one, we use a drug called trazodone. Now, trazodone's principal indication is actually depression, and its side effect is helping you sleep. So it really serves a dual purpose. You know, depression is not something that's finite. Okay, you're depressed. Okay, you're not depressed. It's all shades of gray.
Right.
And so no matter where one is, trazodone has turned out to be a very effective drug.
Trazodone, you have said, is non-addictive.
That is correct. It is non-addictive, but we'll get into drug therapy later. But what I'd like to do is talk a little bit more about risk factors and some that are particularly germane to our residents. So as we get older, as we've already said and we know, sleep changes. The quality of our sleep changes. So when we look at individuals above the age of 65, which would probably include, I imagine, 99%, if not more, of the individuals here, 1 out of 2 individuals is going to have problems with sleep. So that's part of the normal aging process, that there are changes occurring in sleep, and you may not be sleeping as well. Again, one of those 4 symptoms. You know, you can't fall asleep, or you wake up too early, or you wake up repeatedly, and then you can't get back to sleep. So one or several of those symptoms may exist. So to be aware that you're going to have this problem, and to be aware that the treatment for this is not just medicines, but really looking at underlying conditions is important. So the prevalence is high as we get older, and it is in Green Spring. So another issue that's important to Green Spring is insufficient exercise. So because of mobility problems, a common misconception is, oh, I cannot exercise because I have limited mobility. Well, you can still go to the fitness center. We've got an excellent fitness center, excellent staff. They'll assign you a trainer, and there are a lot more things that you can do than you think you are capable of. So please test your potential in the fitness center, because you can exercise, and you can certainly do chairlift. You know, so it's just a matter of prioritizing that, because exercise is good not just for helping you sleep, but it's good for your overall health. Whichever way you do it. Walking after dinner would be excellent. Walking 30 minutes a day will help you not only sleep better, but improve your overall health as well. So in addition to, exercise then leads us into the next problem, which is important for our resident group, and that is being overweight or being obese. So if we eat a big dinner, which is the biggest meal here, and then you're not doing much except sitting down the whole evening, playing bridge is good. I don't know what time folks play bridge here, or what time some of those activities might be. But if the only activity after dinner is sitting, then you're not really burning up any calories. So the increased weight gain is clearly an issue. You know.
All right, I think we can all relate to all of these things.
I'm looking to see if there's anything else I wanted to mention. Yes, a couple interesting things. So if you have a PhD, you're at risk.
Wait a minute, what?
So there are associations that the more highly educated you are, the risk of sleeping disorders is higher.
Now, does that make any sense whatsoever?
I think it does, actually. And
All right, tell me what the connection is.
So I think, now this is speculative, this is not science that's written down, but you know, what does education do for us? It teaches us critical thinking and to think about things in different ways. So the more you think, you don't allow your mind to rest. Just like your body is maybe resting too much, your mind may not be resting enough. And as we'll talk about, you know, cognitive behavior therapy as we go forward, you know, relaxation physically and mentally is important. That's why we talk about winding down and, you know, turning devices off before we go to bed so that our mind is not that active. Speculative, but, you know, That's
Oh,
what
for
it is.
heaven's sakes. Well, there's the downside.
There's a downside, yeah. So also, in our demographic group, concern about sleep disorders should be significant, both on the part of residents because you're experiencing it, and on the part of physicians because we see certain problems that are going to occur as complications. So the two that are foremost in my mind, and we certainly see them, are increased risk for falls. If you haven't slept well the night before, you're not as alert, and therefore a fall may be more likely, not because you're doing anything else differently.
Right.
And the second one, of course, is, as we talked earlier, the risk of depression. You don't sleep. And that becomes depressing after a while because you think, oh, I can't do anything because I can't sleep. So those two are particularly important for, our folks here. Right.
Okay. I think we don't normally think about talking to our doctors about sleep problems.
Right.
So I think that in itself is an extremely important message.
Yes, I think so. So we've talked about insomnia, but I think that we should, just in passing, because we can't really dwell on it in any detail, is talk about some of the other sleep disorders.
Yes.
So the one other sleep disorder that we see a fair amount of here, of course, is obstructive sleep apnea. And that usually gets picked up, when someone will tell you, oh, I snore a lot, or, there's someone else in the apartment with you, and, friend, spouse, significant other who says you snore a lot. And that's usually how it comes to light. So sleep apnea these days is very easy to treat. The equipment has gotten better. It does require a visit to a pulmonologist so that we can get appropriate equipment and settings.
Now, do you have to go to a sleep lab and to be diagnosed?
It used to be that we had to do that,
Yes.
but now, in fact, that can be done in the apartment itself.
Oh, it can?
So you don't actually have to go to a sleep lab.
All right.
It may be that that's what your pulmonologist tells you to do, but there are other options available.
All right. That's good to know.
Yeah. And then the other one we should mention, which we see a fair amount here, which can be debilitating to some, is restless legs.
Yes.
When folks go to sleep, they'll say, oh, my legs keep moving, or sometimes they even become painful, and it's interfering with my sleep. So that's where help is available. And we do have very good medical therapies that we can prescribe. And if the restless legs get better, then you can sleep better. So the treatment for restless legs is not to give you a sleeping pill, but to specifically address the restless leg syndrome and give you something that is more
treatable.
targeted. Yeah, that is more targeted. And then the other one to mention in passing, much less common, and we see it in some individuals. Usually it's reported by someone else. These are some REM sleep disorders which are associated with behavior disturbances. An individual may go to sleep but wake up in the night shouting or yelling or crying or something like that, and it's usually reported by someone else who's present. Individuals who have this problem are at risk of developing Parkinson's in the future. So, and about half of the people will go on to develop Parkinson's. Can we truly say that this is predictive? No, but again, this is an association, And the last thing I want to mention, because it's so fascinating, is narcolepsy. We have some individuals.
Are there people here with it?
Yes, yes. And again, there is treatment available for that, targeted therapy that is available for that. So these individuals are like you and me. We're sitting, I can be talking to you, and the next moment I can be asleep. But I can wake right up and talk to you again too. So it's very interesting. So what other questions do you have, Marcia?
Well, I think the whole issue of people getting really addicted to sleeping pills
Yes.
is one that maybe you could address, because
Yes.
I know I have friends who are.
Right. So let's talk about the treatment. We alluded to that earlier and said, if you're having a sleeping problem, don't think that the answer is a sleeping pill. So I want to revisit that. So what are the 3 things that are available to us when we have a sleep disorder? Even before we talk about the treatment, is to remember to discuss it with the provider so that we can figure out what we need to do. So the first step is to treat the underlying conditions and to reiterate and reaffirm what we said earlier, treating the underlying medical conditions, chronic pain, diabetes, right?
Depression.
And then the psychological problems,
psychological,
anxiety and depression.
Yes.
Certainly treating those comes first and foremost.
Okay.
We have drug therapy, and we'll go through it quickly, not to be dismissive, but then talk for a few moments about cognitive behavior therapy for insomnia. Yes, so most people may not have heard much about cognitive behavior therapy. It exists for all kind of conditions, but it's particularly important in insomnia. And where this comes from is essentially that we have too many people taking sleeping pills, prescription and non-prescription. So in the non-prescription category, we've got drugs like Benadryl, which people can be taking for many reasons.
Is that addictive in any sense?
It's not addictive, but because it hangs around the body for a long time, it impairs you the next day. It keeps you dopey, groggy, drowsy, and you're not really quite yourself. And it is one of those that is not recommended for folks in the age group that live at Green Spring for that reason, associated with increased falls. While that is true of all sleeping pills, it's certainly true of Benadryl, but because it's over the counter, you don't think it's going to cause a problem. Some people can take 2 Benadryls a night, 50 milligrams a night. It's too much. Not recommended at all. Amongst the prescription drugs, we have 2 major categories. We have the benzodiazepines, or benzos as we call them for short, and the non-benzos. So the benzos, if you take them, you'll recognize them. They are drugs like lorazepam, drugs like temazepam, lorazepam being the commonest one. Years ago, it used to be diazepam, but the use of that has gone down. So they can help you sleep, but they are also addictive. You take them for long periods of time. They're like any other addiction, like opioid addiction, like smoking, I guess we can call it that. Alcohol is more a habit, but can also be an addiction, but addiction to anything. So we need to be particularly careful with that. So the recommendation for whether we use the benzos or the non-benzos is to use it for the short term. And what does short term mean? Short term means days to weeks. In some instances, it may be a month or 2. And you might say, well, you know, I've been taking it for a long time, or I know people who've been taking it for a long time and nothing's happened. So while I'm very bad at analogies, I will give you a medical analogy here. And that is hormone replacement therapy. Early on in my medical career, I remember one of my colleagues saying to me, I take hormone replacement therapy because I don't want to have a heart attack like my mother did. Well, guess what? We gave it for so long to women that we ultimately found out through the Nurses' Health Study that we could not offer any protection for heart disease, right? Instead, we increased the risk of breast cancer. And we found out 20 years later with long-term use, you can also get kidney stones. And guess what? My own mother had both of those problems. So, you know, just because something doesn't give you a problem in the short term or the medium short term, the absence of demonstrable risk doesn't mean there's no risk. So what is it that we need? You know, do we need people to fall over, break limbs, which they do anyway? What do we need to prove? Nothing. So that brings us back again then to drug therapy, days to weeks to months. So I'm going to give you now my perspective. Sometimes I feel like it's a tussle between the resident and myself, and the resident will say, well, I hope you're not going to take this away.
Yes.
So I'm not sitting there to take away or give away. I'm sitting there to help you do what is optimal for your condition, which will give you benefit with the least risk. And if I can give you a benefit, but I can also create a big risk for you, then I'm not fulfilling my Hippocratic oath. I was almost going to say Socratic oath, but Hippocratic oath. Right. So, there is risk to you in taking those.
Yes.
Apart from addiction, the falls, the depression, those are real, those are demonstrated. That is what we call class 1 evidence.
And those are serious.
Yes, and so, the residents really should not pressurize their physicians. And what the providers need to do is they need to talk to you about what other help is available. Now, you may not be taking a benzo, but you may be taking a non-benzo, and these are the newer drugs. So their benefit was supposed to be that they're shorter acting. So for instance, Lunesta and Ambien, same addictive potential.
Yes.
And therefore not good for the long term. So when we had very high Ambien use here,
Yes.
Erickson did something very good. The medical group in Erickson decided we needed to reduce Ambien use because we were creating
Yes.
risk for ourselves. And there's been a nationwide initiative within many big hospital and physician groups to reduce the use of hypnotics because of the increased risk of falls. So, if nothing else, physical safety is something we can relate to immediately. So, cognitive behavioral therapy can be thought of in a very simple way. These are structural programs. There are many protocols which have many names, and I'll give you some of the names in passing. But basically, what these protocols do is they take behaviors and thoughts which are going to prevent you from sleeping or create sleeping difficulties and replace them with better behaviors and thoughts. Example, I'm anxious right now. It's 10 o'clock at night and I think, well, I'm not going to sleep. So I start pacing because I'm just anxious. Or I say, well, you know what? I know I'm not going to sleep. And I go to the fridge and I get something to eat. Or if I'm having a drink, maybe one isn't good. I say, well, I'll have another one. Okay. Between the anxiety and the alcohol and the pacing, working yourself up, or if you're spending too much time reading, the TV is on really loud, or your computer screen is in front of you, your laptop, your iPad, your phone, whatever, then all of these are creating a negative influence from you and preventing you from sleeping. So you need to think, how can I change this? So cognitive behavior therapy is about creating a discipline for sleep. And I'll name a few for you. There is what is called sleep prevention, oddly enough. There's another one called stimulus control. Another one is called sleep behavior environment control. But all of these, I lump them all together into what I like to call sleep hygiene. So sleep hygiene is to sleep what personal hygiene is to your body. So what does sleep hygiene constitute?
Wow, now Dr. Sethi, I don't think any of us have ever heard of this.
Well, that's
or
why
most of us have not.
Yeah, so that's why I thought it would be good to share this information.
Absolutely.
Yeah.
How can we find out more about this?
So you can find out more, but I'm going to tell you a few things which
right.
intuitively you know, but now you'll be more aware. So this is the yoga for sleep, as yoga is for the physical body, right? So the first thing is, as much as you can, go to bed and wake up at the same time each day, okay? Make sure that you turn off TV and all things for an hour or two before you sleep. Put down your laptop, put down your iPad, relax. So those three things for sleep hygiene: wake up, sleep at the same time, remove the noise, and turn off your mind.
Stimulation.
Yeah, turn off your mind, and then relax. Use music, calming sounds, imagery. Think happy thoughts. Think happy thoughts.
I think many of us have discovered that.
Yeah. So intuitively
breathing,
we know this.
Exercises, relaxation.
Yeah. Yeah. All of those techniques are good. So sleep hygiene just simply means you're thinking of sleep just in the same way when you get up in the morning, you have a routine. Before you go to bed, you have this routine as well. And it works wonders.
I think I see that our time is up.
Okay.
I think that's a wonderful note to stop on. That these things can improve health and improve sleep.
Yeah.
Sleep and health.
And I'll just close by saying, for more information, you can read about cognitive behavior therapy for insomnia. Just Google that and you can get a lot of information.
All right. Again, this is not a phrase that I've ever heard anybody here use, residents.
Right.
So I think that's extremely important.
Very good.
Well, this has been very helpful and very interesting since we're all involved with sleep. We do it all our lives. Anything else you'd like to leave us with?
Have a good night's sleep tonight and think about what we spoke about.
All right. Thanks so much, Dr.
Thank you,
Sethi.
Marcia.
That was very helpful.